Warning: the podcast you're about to listen to may contain graphic descriptions of violent assaults, murder, and adult language. Listener discretion is advised. Welcome to the Murder Police Podcast, Forensic Pathology with Dr. Greg Davis, Part 2 of 3.
But I'll tell you what, now would be a good time actually kind of because you touched on it, and let's shift into it. For these people that are interested in the career, and I can tell you we have a large listener base of people that really consider things inside the criminal justice field and inside investigations a lot. What would you tell somebody that was interested in anything where you've been, how to prepare, what mindset to have, what they could do? What would be some advice you'd give that person?
Well, first of all, as I mentioned before, it requires going to medical school. And I'm going to give a free piece of advice, a trade secret. For those listeners who think about going to medical school, when you write your personal statement, my suggestion is, I don't want to be prescriptive. I don't want to be, that guy. But I review a lot of essays from people who want to go to medical school that say things like, I've always been interested in the human body. Well, so is every other human being that was ever born. My unsolicited advice is, if you can get across that you're also interested in people. And again, I hate to be a harp back to this ad nauseum, but it's all about the relationships. I mean, if anything is going to keep us sane and engaged and having fun with what we do, it's those personal relationships. So I really don't want to hear in your essay that you're interested in the human body, because that's like saying you're interested in breathing. We're all interested in that. I want to actually know something about you and why you're interested in people and why you're interested in becoming a physician. So what I tell those young people, and sometimes not so young people, we have a lot of non-traditional medical students who've had other careers before they go into medicine. We've had culinary chefs, we've had engineers, we've had lawyers, we've had nurses, and we've had people straight out of college come to medical school. But it's in the North American system, it's 4 years of college, 4 years of medical school, and then you apply for residency training. Residency is specialty training. So if you want to be a pediatrician or an OBGYN or a surgeon or a pathologist, you apply for residency in that specialty. And the 4 years are training in anatomic and clinical pathology that we talked about before. So you build this foundation now for 8 years after high school to get your MD or DO. They're essentially the same. And then another 4 years. So that's 12 years after high school. And then one additional year of training in forensic pathology. So when you hear the word fellowship, that means subspecialty training. Forensic pathology is a subspecialty of pathology. And at that point, once you finish your training, as I mentioned before, you then are qualified by your training director to actually take the board exams to become a board certified forensic pathologist. So it's a long road. It is a difficult road. As that nurse said to me back in the 70s, you don't have to be a genius, but you have to work really hard. You can also have a life while that's going on too. I mean, people do, have personal relationships and raise families and that sort of thing, even in the midst of this, but it's not easy. And I think that's the informed consent that I like to give people thinking about doing this, is it's not easy. I think another misperception is your whole time is doing autopsies. The word autopsy comes from Latin and Greek roots. Auto refers to self, opsy like optics, optical. You're just looking for yourself. You're not taking somebody else's word for it, why this person died. And so what I tell these folks who are interested is, yes, I get a lot of intellectual gratification out of doing a good physical exam of a deceased person. The first part is an external exam, just like you'd get at a doctor's office. The second part is the internal exam through those incisions. The third part is looking at the microscopic sections of heart, lung, liver, etc., and looking at the toxicology results. Perhaps it's a drug intoxication or poisoning or something of that nature. So that's sort of the third part. And then you put it all together in a synthesis to do a final report that goes to the coroner and ultimately to family members, law enforcement, prosecutors, defense attorneys, etc. That communication is really the most important part, because the autopsy in and of itself is a laboratory test, and laboratory tests are worthless unless you can interpret them and what they mean in the context of a particular case. The teaching example I always use in court is an autopsy is going to look the same if somebody jumped off a building, slipped off a building, or was pushed off a building. And so working with the coroner, working with law enforcement to try to figure out how did that person leave that roof, that's going to make a huge difference in the manner of death: homicide, accident, natural, suicide, not determined, versus the cause of death, which is going to be the same in all those scenarios, which is acute deceleration injury, blunt injuries from a fall. But that's that communication, that interpersonal availability, if you will. I think, again, it's what keeps people sane, engaged, interested, and avoiding burnout. I mean, burnout's a huge issue in medicine. It's a huge issue in law enforcement. And I don't mean to say I have all the answers, but I think one of the huge causes of that is forgetting why we're here in the first place and forgetting that idealism. Whether you go to the police academy or go to medical school, your first goal should always be you wanted to help people, not that you wanted a badge or a stethoscope around your neck.
Good point, because I think in our industry, that's something where it goes wrong is there's a little disillusionment going in. And then not enough intrinsic gratification. It turns into extrinsic, and that police are dealing with that everywhere right now too. So for sure, if somebody's interested in this, one of the things that's not going to be in the textbooks is having some people skills. And that's what I keep catching from you, and I agree completely, is that none of this is that technical. The technical part is going to take some work, but I would agree. I can't imagine ever sending a case to you all back when I was in the unit and us being back at the office. Because we went. I mean, this wasn't a phone call. I'm almost laughing because I think it happens in some places. Or when you talked about in North Carolina where the coroner's like, well, I just don't have time for this. I'm going to send it to you. I can't imagine that and what the lack of result might be in the frustration.
Well, and I wanted to ask also, that was some great advice you gave for someone who may be looking to enter this career. But on the flip side of that, what advice would you give to detectives or law enforcement that has to work in conjunction with you in your office?
I think get to know us, just like the same advice I give to my folks is get to know law enforcement, know their names, have coffee with them or a meal with them, because you are interdependent. They need the information that you glean from the autopsy and the microscopic and the tox. But you also need them to tell you about the circumstances of the scene and confessions. We talk, I'm sure this is probably true in law enforcement too. I can't speak for law enforcement, but I can speak for forensics. We talk a lot about the holy trinity of death investigation, which is physical evidence, confessions, and witnesses. And we all know that witnesses are often wrong, maybe they're not telling the truth with intent, but just because we're humans, we get it wrong. I mean, I still remember high school physics class and it's probably get in trouble for them doing that now, but they had a guy run into my teacher had a guy run into the classroom with a meter stick, a yardstick, and bang it on the table and scared the, what out of us, and then run out. And so we're all sitting there kind of shaking, like, what happened? And then the teacher says, get out your pads and pencils and write down everything you saw. Well, one guy said he was dark skinned wearing a hat. Another guy said he was light skinned, not wearing a hat. And so we take witnesses with a grain of salt. confessions sometimes can be forced or wrong, or a person who's mentally ill may confess to something they didn't do, or they may be covering for somebody. Physical evidence doesn't lie, but it can be misinterpreted. I'm holding up a blue Bic pen. The science of medicine is we can all agree it's a pen. It's so many inches long and it's blue. The art of medicine is, well, what does that mean in the context of this particular case? Like a tox level, a person who has substance use disorder can be walking around Vine Street in Lexington with a level of heroin in their blood that would kill the three of us 3 times over. So did she die from that heroin, or did she die with that heroin from another cause? That can be an important distinction. Just understanding that, again, things aren't always black and white. And David, as you said, aren't always as they seem right from the outset. We have to be careful about preconceived notions. And what I tell law enforcement and my folks is the biggest trouble I've ever gotten into professionally is when I go into a case thinking, oh, I'm doing air quotes, this is a typical case of fill in the blank, because you're inextricably bound to get burned when you think that way.
Like making impressions on people in 30 seconds. Yeah, that's the story. Yeah, I've done that forever. And I think we're all victim of it, where you walk in a room and you start to make assumptions on people within a fraction, not even a whole minute. And I've never had that not be incorrect in the end.
And David, I wanted to follow up on something you said about people skills. For those listeners who maybe think, well, I'm an introvert, so I can't do this. I am an introvert. There's a big, I can fake it, that I'm not, but there's a big joke in engineering and medicine and pathology and some other specialties. What's the difference between an introverted pathologist and an extroverted pathologist? Well, an introverted pathologist stares at his shoes when he's talking to you, and an extroverted pathologist stares at your shoes. So back when I was in training, if I had to give talks to law enforcement or attorneys or medical students, my voice would be shaking. I'd have sweat running down my armpit. Face would be flushed. And I've gotten better at it over the last 3.5 decades, but there's still a part of me, like many folks have, that's scared to death of speaking in public. But I've also come to enjoy it because I live for that moment, like when I'm testifying in court, where, that juror on the second row who's already angry because she's only getting paid $12 a day and still has to pay for her parking and really didn't want to be here in the first place. If I explain things in a plain English way that's not using a bunch of jargon, that's not condescending because she doesn't have the same medical vocabulary I have, and I see her kind of sit up in the chair and start to nod her head as an educator, because that's what we do. That's what the word doctor means. It means teacher. I live for that moment. When I finally connected with somebody. Again, ad nauseum, I just keep coming back to that. That's what really counts. You can be, and I've told my trainees this, you can be the most technically proficient pathologist in the world, but unless you give that surgeon or that family member or that patient or that juror the information that they need, what good are you?
Absolutely. You covered a good point too about I like that, because a lot of people, I think, will talk themselves out of a career path, or at least taking a shot at it because of confidence issues and believing, well, I'm introverted and whatever, without understanding maybe you've got to push that boundary. And Wendy will laugh if you want to hear her say BS is if I tell people when I say this that I consider myself an introvert as well.
He is not.
And there we go. That's the clean version.
He says that, and I will keep it clean today. But you're not.
Yeah,
you're
no,
totally not an introvert. And your face is red because you're getting called out on it. And I don't think Greg is either, but I don't know him.
That's the introversion.
Obviously as well.
Yeah, exactly, the shyness. But what I'm getting at is that, that's a neat thing for people to hear, especially when they're young, because what follows that is things like imposter syndrome and the things that get on your shoulder and tell you that, no, you can't. Or like when it takes me back to your story, medical school. I'm not smart enough. And then somebody somewhere hit you with that neat club of, You don't have to be smart. You got to work hard. So I love that.
I'm so glad you brought up imposter syndrome. I have struggled with it all my life. I think a lot of the good docs and cops and others that I know have struggled with it. There's a part of me after, 20 plus years of being a professor that thinks, well, when are they going to find out how dumb I really am? and I think, that can also be used for good or ill. To have some of that in your soul is always a catalyst for trying to do better, for trying to learn more, for continuing your education, for looking for that constant quality improvement. What can I be doing better? But you don't want to tip over into the other side of it crippling you, where you can't do anything because you're always second guessing yourself. But I remember being really nervous. I was testifying in a case for the defense in Sevier County, Tennessee, right next to Knoxville, the home of Dolly Parton, who, if she's not already,
we're talking Gatlinburg.
That's next county over. Yeah,
yes?
Sevierville. And if Dolly Parton's not your hero now, you need to learn more about her, and she will be.
She's awesome.
And her statue, I think it's a 16-year-old Dolly, a statue of hers in front of the courthouse in Sevier County. But I was really nervous because it was a high-stakes case. But my brother from Knoxville, who is an attorney and a physician, came to watch me testify and critiqued me afterwards. So that made me a little bit nervous too. But at that point, I'd been doing this for about 25 years, and he pointed out, all big brother water under the bridge stuff aside, he pointed out some really good things that I was doing that distracted the jury. So, for instance, swiveling in my chair too much, opening and closing my water bottle, and they were obvious nervous tics, and that got across to the jury because, again, I still struggle with public speaking to some degree. But there's always room for improvement. But yeah, for any listeners who think, well, I'm too shy or I'm not good enough, that may be the case, but give yourself some credit and try to feel others out in the field that you're interested in to see if you're the right fit.
The roar of a lion forces Savannah to choose if she'll save her classmates or be the next featured story on the Murder Police podcast. Hi, I'm Christine Meyer, author of The Too Tall Giraffe, a children's book about looking different, fitting in, and finding your superpower. After 20 years with the NYPD, I now help kids embrace their differences, fit in, or not, and find their superpowers. You can learn more at thetwootallgiraffe.com.
I always counsel medical students, if you're shy around dead bodies, that doesn't mean you can't be a pathologist, a forensic pathologist. I was super shy. A lot of this is acclimatization. And Wendy, you and I talked offline about this. There are things you don't ever get used to, but you get acclimated to them. I will never get used to seeing somebody die by violent means, but I've sure gotten acclimated to it over the years. But it takes an emotional toll, not just the physical toll of standing up, for hours on end, or standing at a scene, or, getting up at 3 a.m. to go to a crime scene. And I was a scene investigator for 5 years in North Carolina. But there's an emotional toll as well. And I know this is true in law enforcement. I know it's true in medicine.
And you're going right where my question was going to go. You're right in law enforcement. We've talked about on previous shows how that detective takes that back home with them. It's not just you leave the scene and it's over and now you're home kicked back in your recliner. I was going to ask you, does that, because of the graphic nature and what you do, does that affect you in that same way? Do you go home and, let's say maybe it's an infant or even if it's all the same to you, does that affect you in that same way? Or do you truly are you able to leave the job at work?
The answer to the first question is yes, it affects me. And the answer to the second is no, I can't leave it at work, but I can do things about not leaving at work. I can't compartmentalize completely. I can compartmentalize when I'm actually doing the investigation or the dissection. I'll use an analogy for you. My dog Terrence, back when I was a medical student, was a basset hound, and he got a coat hanger in his eye. And at first I thought the coat hanger had pierced the globe of his eye. It hadn't. He'd gotten it caught between his eyelid and his eyeball. He ended up being perfectly okay. But he was howling and screaming, and I just walked over to him. I grabbed his head, and I gently extricated the coat hanger, and then I sagged down to the ground and burst into tears. I mean, so I was able to get the job done and then just sort of have a little mini love my
little
dog
small meltdown
breakdown
thereafter.
afterwards. Yeah. But I think healthy, there's unhealthy coping mechanisms and there's healthy coping mechanisms. I have not met a human being in my life that didn't need, whether we want to call it counseling, debriefing, therapy at some point in their life. And I don't care if you're the most buff cut cop on the planet or the most, battle hardened physician, you are going to need counseling or therapy. And I always tell people it takes strength to admit when you need it. It's not strength to avoid it, because it will come out. Shakespeare said murder will out, meaning if you commit a murder, it's going to be found out at some point. And I think stress will out as well. So, which would you rather do? Come home and drink too much and have a failed relationship and kick the dog, or get some therapy or counseling if you don't want to call it therapy, or debriefing if you're macho, that sort of thing. And whatever you call it. After the 5191 crash at the airport, one of the things I loved the mayor of Lexington for doing, Mayor Isaac, made counseling available to every police officer, firefighter, coroner, medical examiner. I availed myself to it just because that was so stressful. But it does take a toll. I mean, for the partners of people who do this kind of work, they're obviously asked to do a lot to accommodate the nightmares that some of us have. I still have nightmares about certain cases. That's just part of who I am now. And so, again, when young folks come to me, it's again a constant balancing act. I don't want to quench anybody's enthusiasm, and goodness knows we need more young people going into forensics. For those of you who are interested in forensic pathology, it is a buyer's market. As far as when you get your training, you could probably go anywhere in the United States and get a position, because we are in a demographic crisis. It's a graying profession. I'm in my 60s. I'm probably close to the average age of a forensic pathologist, and we need an influx of new folks. But recognize that, it's not all glamour. When you go to a scene at 2 a.m. of a lady who's been beaten to death by the guy she hired to do some yard work the day before, that's a lot of stuff, but it ain't glamorous.
Now, do you ever have direct contact with surviving family members, or do you not have that relationship in your career that you have to do that?
It depends on what the family wants. Usually the coroner is the point person for communications with family. But if the coroner says, hey, Greg, I've got this family here, and you discovered some coronary artery disease in the young father who, didn't have any past medical history, and they want to chat with you about potential risk factors for their kids or his siblings, that sort of thing. I'll talk with families. I'll always advise them in that context to go to their primary care provider for proper screening, because I don't take care of living patients and haven't since the 80s. But yeah, we'll talk with families if they want to. And generally, the two biggest questions we get are, did my loved one suffer? And did you discover something that's of importance to the family that might have an impact on our kid's health or her brothers and sisters' health, that sort of thing. And we, in response to that first question, it's our mamas taught us, it's not what you say, it's how you say it. And I will never whitewash the truth. I'll never lie to a family about that, because once you lie about one thing,
you got to keep right online about
well, yeah,
the next thing.
And you can't be trusted after that. So, but there are lesser harmful ways of getting information across to a family. We don't get a lot of hugs in my profession, but pre-pandemic, I got a couple from family members, when I was able to honestly tell them that based on the physical findings at autopsy, their loved one did not suffer.
They're just looking for answers. Good. And I'm with you too. I think sometimes it's the way you deliver it. Because I remember a lot of the huddles that we used to have with families where you met a family and you became their advocate if you took a case. And that was probably my most rewarding part of that job is it was very humbling. Then the other big huddle you had that took a lot of coordination with the medical examiners and with the coroner was for example, in a suicide. Because I've always told people putting down accurately whether or not that was a suicide sometimes took more work, if that sounds right, than a murder investigation, because you can't get that wrong, because that determination for the family is huge. And to be able to have enough facts for them to walk them through that as gently as you can, but to erase doubt. That's a huge issue. I just remember those conversations. They were difficult, but in the end, you knew you were doing the right thing.
Well, and that brings up secondary conversations that I think your profession and mine often have with families, and especially in cases of a completed suicide, is what could I have done? What did I miss? And, I'm no psychotherapist, I'm no psychiatrist, but I am a human being who's seen a lot of this. And what I have told families before is nothing. You could have done nothing. There are plenty of ways we can treat suicidal depression or impulses, but at the end of the day, if somebody is bound and determined to do something, there's not a whole lot we can do to stop them. I mean, it's like, I think the chief of police in Louisville or the Jefferson County sheriff was talking about that sheriff's deputy that was murdered recently over there. And she said, if somebody's bound and determined to kill somebody, there's not a whole lot we can do to prevent that, but we can sure bring him to justice afterwards. And, that's something I've seen a lot is family guilt, not just in suicide, but in death of a child from sudden infant death syndrome, which we now call sudden unexpected death in infancy, which is just a way of saying we still don't really know what causes it. And we call it by this different name now because people have been acculturated to think that SIDS is a diagnosis, when in actuality, it's just an admission that after we've done our due diligence and tried all of our diagnostic techniques, we still don't know why that child died. And yet we have parents who often think, I should have done something different. I should have given them this food instead of that food. And we have to reassure them that, there's no way to say that caused the infant's death. And the other thing we do to educate, I still remember if folks are aware of the back to sleep program, the received wisdom when my babies were little was you put them to sleep on their tummy in case they vomited, they wouldn't aspirate and suck the vomit down their windpipe. Well, we now know we have this back to sleep program where pediatricians will tell new moms and dads, put the baby to sleep on her back. And part of that is there is a decreased incidence of sudden unexpected death in infancy with babies who sleep on their back as opposed to babies who sleep on their tummy. But that doesn't mean if you put your baby to sleep on their tummy and they die of SIDS that you killed your baby. Association is not causation. And years ago, a JAG prosecutor at Fort Knox wanted to prosecute a mom and dad because they put their infant to sleep on their tummy and the baby died of SIDS. And folks in the Louisville office had to call him up short and say, that dog won't hunt, as we say in Kentucky.
Can't get those wrong.
No.
Can't get those wrong. That's a big problem with that too.
And I think a parallel to can't get those wrong, David, is admit when you are wrong and don't be reluctant to change an opinion. I mean, we always joke that we do it on paper or now electronically. We don't chisel our opinions in stone, because if you or a family member brings me reliable information later on down the road and I have to rethink the case, I shouldn't have so much ego bound up in it. Dr. Davis is always right, that I'm reluctant to change my opinion.
Good point. I don't think even the ones that we cleared, if somebody came back 20 years later and said, something's different, I'd say, oh, wow, well, let's look. I mean, because you just know that you take what's in front of you at the time and you make the best decision you can at the time, but there's always that little piece. I agree with you that you have to be ready for a change if that comes up. When you're talking about your career and getting started again, I know we're meandering, but it's actually a fantastic conversation. This is really good. But when you're talking about the mindset coming in, were there things that happened early in your career that were unexpected that shaped you later? Were like disappointments or anything?
Well, I'll start with the opposite of disappointments. So I started my pathology residency convinced I was going to be a community hospital pathologist. I was going to be the guy at the community hospital who did surgical pathology and, read the biopsies when the gastroenterologist did a colon biopsy or the dermatologist shaved a mole off somebody's skin, and look at pap smears and run the blood bank and run the clinical chemistry lab and the microbiology lab. That's where my initial interest lay. My very first rotation as a pathology resident was 2 months with the Office of the Chief Medical Examiner in Louisville. I did my residency at University of Louisville affiliated hospitals. That medical examiner's office had a relationship. It was also the division of forensic pathology of the Department of Pathology of U of L. I started the rotation on July 1 thinking, okay, I've got to endure these 2 months at the medical examiner's office, and then I can go on to doing what I really want to do, which is surgical pathology. Within a week, I knew that forensic pathology was what I wanted to do. Dr. George Nichols, Dr. L.C. McLeod, Dr. Barbara Weekly-Jones, they were taking me to crime scenes. We were following up doing autopsies. And it was not the autopsy in and of itself, the lab test that really hooked me. It was these people. They were cheerful. They were hardworking. They had an appropriate, good sense of humor. They'd been doing it for quite a long time and yet seemed still engaged and happy. While I enjoyed my training in those other areas of pathology, within probably 2 weeks of that rotation, I thought, this is what I'm going to do. As far as disappointments, I don't mean to sound like a Pollyanna, but 35 years later, if I could do it all over again, I'd do it all over again. I made the right choice for me. And for listeners who are thinking about a career in medicine or a career in pathology, one of the really cool things is, and maybe I bet it's similar in law enforcement, no matter what your personality, no matter what your interest, there is a place for you in medicine if you think that's what you want to do. And pathology is like a microcosm of medicine as a whole. I mean, we're sitting right now in the Department of Pathology at the University of Kentucky. About 10 feet away is the office of my work sister, who's a neuropathologist. She does mainly surgical pathology and diseases of the brain and spinal cord and muscles. Her day-to-day work is a universe away from what I do. And yet we're both pathologists. We're both physicians. Another buddy of mine down the hall is a blood banker. 100% of his professional time is transfusion medicine and working in the blood bank. I'd be a lost puppy if I tried to do any of that stuff. And yet we're both pathologists. So that's one of the joys of this profession. And I've never been bored. I've never regretted my decision. Now, that doesn't mean I haven't had bad days. And I think, we've talked about cases that haunt you and the fact that this takes we will, and that this can take an emotional toll. But on balance, the reason I'm still loving what I'm doing, even at my somewhat advanced age, again, are those relationships and those people.
As Simon Sinek would say, you have a strong why. And I love that. That's one of the most profound things I learned in the last few years is that how important that is for all of us is that why, and how can we stay true to the why is a difficult, especially when it throws you things. Because I'm the same way. Is that during my career is that there were bumps, but they never outshadowed the enjoyment I got out of the career and the satisfaction of getting things done well. So that's a good atmosphere.
That must have been tough for an introvert like you.
Well, it was. Yeah, exactly. And I'm finding it very difficult to speak on it now. So thank you for being patient.
Greg, I was going to ask, you talk about, and I don't want to dive into it to relive bad memories for you, but
that's okay.
You talked about the cases that haunt you. And I think much like I mentioned a few moments ago, there are those things that you just can't get out of your head, for lack of better terms. For you, are the cases that haunt you, are those the cases of brutal death, or what is it for you that just, when you walk in that day and you know that's what you're facing, or when you walk in that room, what is it for you that you think, I'm going to do it, but this isn't my preferred day? Hey, you know there's more to the story, so go download the next episode like the true crime fan that you are.
The Murder Police podcast is hosted by Wendy and David Lyons and was created to honor the lives of crime victims so their names are never forgotten. It is produced, recorded, and edited by David Lyons. The Murder Police podcast can be found on your favorite Apple or Android podcast platform, as well as at murderpolicepodcast.com, which is our website, and it has show notes for imagery and audio and video files related to the cases you're going to hear. We are also on Facebook, Instagram, Pinterest, LinkedIn, and YouTube, which has closed caption available for those that are hearing impaired. If you've enjoyed this podcast, please subscribe for more and give us a 5-star review on Apple Podcast or wherever you download your podcast from. Subscribe to the Murder Police podcast and set your player to automatically download new episodes so you get the new ones as soon as they drop. And please tell your friends. Lock it down, Judy.